A very good afternoon to all. It is my privilege that the Department of Orthopedics has been given the opportunity to present the CCR this time. We orthopedicians are usually considered as carpenters, but today it is all about carving a stone, which is definitely not a child's play. A 10-year-old female presented to our emergency department with a history of trivial fall at home. She complained of pain and swelling in the left thigh and was unable to bear weight on her left lower limb. On clinical examination, we found that the left thigh was tender and swollen. There was pain on minimal movement of the left leg, and there was deformity of both the legs. Also, the patient was hemodynamically stable. So, we did a general physical examination on which we found that the patient had short stature. The anterior fontanelles were open. The patient has proptosis with Louis sclera of both the eyes, and the patient had some syndromic facies. There were small fingers and toes and procurvatum deformity of bilateral legs, as you can see in the photographs. So we did an initial radiographic assessment of the patient with an X-ray of pelvis with both legs, and we found out that there was a transverse fracture of the shaft of the femur with valgus deformities at both the hips. Also, as you can see, there is generalized increased density of bone with no narrow medullary canal in long bones. A femoral shaft fracture is not an uncommon thing for an orthopedic surgeon to find in an emergency department, but they are usually spiral, oblique, or comminuted. This kind of fracture is an atypical femoral shaft fracture, which is very uncommon. And in this inset, you can see this is a classical case of atypical femoral shaft fracture in an skeletally mature patient, which is characterized by location in the subtrochanteric region, transverse nature, and a medial spike. So this bone is basically dense. It is dense but brittle. It is like a chalk. So when you try to break a chalk, it breaks into transverse. So we got a skeletal survey to evaluate further, and I would like to call my radiology colleague to discuss the skeletal survey.
Good afternoon, everyone. I shall be discussing the skirt survey for this patient. So as we first see through the frontal radiographs of the left hand and bilateral feet, we see that there's a diffuse increased density with obliteration of the medullary canal. There is non-visualization of the distal aspect of the distal phalanges, which is suggestive of acro-osteolysis. In the lateral skull radiograph, we can see that there is persistently the sutures are wide open, and there are persistent Vermian bones, which are also seen in this radiograph. The mandible appears to be hypoplastic with an obtuse angle. The persistently open sutures, widened sutures are further re-emphasized in these VRTs where the fontanelle is widely open, and there are multiple vermin bones. In the frontal as well as the lateral radiograph of the spine, we see that there is a minimal scoliotic deformity with diffusely increased density of the vertebral bodies. In these bilateral lateral radiographs of the leg, we can see that there is anterior bowing of the middle third of the tibial shaft with break in the anterior cortices. Finally, the bilateral clavicles were present and were normal on both sides. So, in dealing with such osteosclerotic skeletal dysplasia, our two major differentials include cleidocranial dysplasia and pycnodysostoses. The presence of clavicles on both sides, increased density of the bone, as well as the presence of mandibular hypoplasia with the obtuse angled mandible suggests the diagnosis of pycnodysostoses over cleidocranial dysplasia. For further discussion, I would like to hand over the dais to Dr. Anupam.
After this initial radiographic assessment and the skeletal survey, we admitted the patient for further workup, and a pediatrics and a genetics opinion was taken, and we found that there was normal blood counts, the liver and the renal function tests were normal, the serum alkaline phosphatase, calcium and phosphorus levels were also normal, but the growth hormone analysis revealed low levels. So basically we were dealing with some sort of hereditary osteosclerosis, and there are n number of differential diagnoses for hereditary osteosclerosis. But for us, osteopetrosis is one common differential diagnosis for osteosclerosis. But osteopetrosis has got progressive hypoplastic anemia, secondary extramedullary hematopoiesis with hepatosplenomegaly, cranial nerve palsies, and normal facies and hand and feet. But this patient had characteristic facial hand and feet, normal blood picture, hepatosplenomegaly, and cranial nerve palsies. Also, the patient attendants were counseled to bring their old reports, and we found that patient was a known and diagnosed case of pycnodysostoses outside AIIMS. So briefly discussing about pycnodysostoses, it was first described in 1962. There was a famous French painter, Henri Toulouse, was found out to be suffering from this disease posthumously, and this syndrome is hence named Toulouse-Lautrec syndrome, also known as osteopetrosis acrolytica. It is a rare autosomal recessive hereditary disorder, and only 200 cases have been reported so far in the literature. It is basically a lysosomal disorder with a defective cathepsin K protein. Cathepsin K is primarily responsible for degradation of the organic matrix, and defective cathepsin K leads to defective resorption and remodeling of the bone, leading to a sclerosing bone dysplasia, resulting in hard, brittle bones susceptible to recurrent fractures. This is a diagrammatic representation. So cathepsin K is present in the lysosomes, which leads to release of hydrochloric acid, which creates an acidic milieu in the bone, leading to resorption of the bone. And if the cathepsin K is defective, it leads to impaired resorption and remodeling of the bone, resulting in inhibition of normal bone growth. So in the phenotypic manifestations, nearly 100% of the individuals suffer from short stature. They typically develop short stature by early childhood, and nearly 30% of this results from intrauterine growth deficiency. The limbs are often disproportionately short compared to the trunk, with rhizomelia, mesomelia, or acromelia. In the craniofacial findings, the patients usually have a mid-face protrusion due to hypoplastic maxilla, small jaw with an obtuse mandibular angle, frontal bossing, persistently open anterior fontanelles, prominent nose, Lewis sclera with proptosis, and a high arched palate. Coming to the skeletal features, as we saw, the patients have a diffuse increase in the bone density, short hands and feet, progressive acro-osteolysis, especially of the terminal phalanx, non-pneumatized mastoids, and delayed fusion of sculptures. The patients, because of the increased bone density, have increased fragility in the bones, resulting in increased fracture rates and delayed fracture healing. As the patients have osteosclerosis, the surgical fixation is also complicated, and nearly 35% of these patients require an orthopedic intervention in their lifespan. Bisphosphonate therapy is contraindicated in these patients, and there is no medical management to normalize the bone density currently. In the ENT related findings, the patient usually have stridor, laryngomalacia, OSA, and mild conductive hearing loss. In dental anomalies, they have deciduous and permanent delayed eruption of deciduous and permanent teeth and hypodontia. The nails are usually dysplastic, grooved, or flattened. Coming to the radiological findings, as we discussed, they have generalized progressive osteosclerosis and hypoplasia of facial bones, especially the terminal phalanges is characteristic. The mastoids are non-pneumatoid. There is delayed fusion of cranial sutures, and there is obtuse mandibular angle. The vertebral bodies are dense, but the transverse processes are uninvolved. There is clavicular dysplasia and congenital pseudoarthrosis of the clavicle. The modeling defects that are usually seen in osteopetrosis are not present in pycnodysostosис. In the laboratory findings, they have normal serum calcium, phosphate, vitamin D, and alkaline phosphatase levels. The growth hormone is deficient. The IGF-1 levels are low, but there is no abnormality of any pituitary hormones, and the cathepsin K gene mutation analysis is usually confirmatory. In the pathology, they have normal cortical bone, but the osteoblastic and osteoclastic activity is decreased. And in the electron microscopy, you can see cross-banded collagen fibrils accumulated in lysosome. So now we had a patient who is a diagnosed case of pycnodysostosis with a left shaft of femur fracture. So the standard management of a shaft femur fracture is basically you can do four things: either a cast, external fixation, intramedullary nailing, or a plating. So cast is usually reserved for children up to 5 years of age, and as she was 10 years, we did not go for a cast. External fixation has got its own problems of pin tract infections and fractures at the pin site. Intramedullary by far is considered as the best treatment modality currently in the literature. But the challenges in this patient were sclerosed bones, which resulted in difficult to reach in the medullary space. Hence, an intramedullary nail could not be placed. The bones were brittle, hence the handling could not be rough. The anesthesia was also difficult, and there is no defined management protocol for management of such patients. And also, the bony union is problematic in such cases. This is a normal skeletally immature femur. You can see that this is the normal intramedullary canal in a normal adolescent patient. But this is our patient with a sclerosed medullary canal, which precludes the placement of a intramedullary nail. Plating requires drilling multiple holes and securing a plate, but as the bone was very dense, there was a resistance to drilling, which results in heat necrosis, fracture with minimal trauma, increased blood loss, and increased surgical time. We usually use stainless steel drill bits to drill holes, but they were not sufficient to drill holes in such osteoporotic bone. So instead, we used fresh sets of carbide drill bits. So carbide drill bits are made up of tungsten carbide and they are harder with greater resistance to wear and less prone to break. It reduces surgical time and also may potentially reduce the extent of necrosis. So in the preoperative preparation, we arranged adequate blood products in case we have to open up the fracture and fix it with a plate. New and sharp reaming and drilling equipments were procured and backup implants were kept in the operation theater. New drill bit sets were ordered and also a broken screw removal set was ordered. For any surgery, anesthesia is a prerequisite. I would call upon my anesthesia colleague to discuss the challenges.
Good afternoon, everyone. I'll be discussing about the anesthetic challenges which are associated with pycnodysostosise. A 10-year female child weighing 13 kg, she was planned for close reduction under general anesthesia. She was a known case of pycnodysostosise, which was diagnosed at 3 years of age. And her mother complained of history of snoring, difficulty in breathing at night, and daytime sleepiness. She also had history of multiple bone fractures. On general physical examination, the child had short stature, frontoparietal bossing, proptosis, wide open anterior and posterior frontalae, hypoplastic mandible, short fingers. And on airway examination, there was crowding of teeth, large tongue, and Mallampati grade was 3. Her systemic examination and routine blood investigations were normal. A general anesthesia was planned, and because of hypoplastic mandible and large tongue, difficult airway cart was kept. Different size and type of supraglottic airway devices and video laryngoscopes, stilette and bougies were kept ready. ASA standard monitors like NIBP, ECG and SpO2 were attached. A 22 gauge IV cannula was secured, and a child was induced with injection fentanyl after pre-oxygenation with injection fentanyl of 2 microgram per kg and propofol of 2 milligram per kg. After induction, the child had difficulty in bag and mask ventilation, which was managed with oropharyngeal airway, and the airway was secured with Procil LMA size 2 in a single attempt. After induction, the child was positioned with minimal manipulations. After that, anesthesia was managed with oxygen and air with along with isoflurane. MAC was maintained between 1 to 1.2. And for analgesia, caudal epidural was given with 0.2% ropivacaine. And also analgesia was achieved with injection fentanyl boluses and paracetamol. Surgery lasted for 90 minutes, and also anesthesia was reversed with neostigmine and glycopyrrole. The child was extubated when she was fully awake to avoid airway obstruction in the post-operative period because of a large tongue. The total fluids, 400 ml of fluids were given intraoperatively. Since it is a rare autosomal recessive disorder, there are no randomized control trials or large studies on this. Only few case reports have been documented. Here in this, in the first case, Mazur et al. He has reported a 5-year-old child with pycnodysostosise, and she was operated for fracture shaft of femur under general anesthesia with difficult airway, which was managed with video laryngoscope. And in the second case, she was Puri et al. Has reported a pycnodysostosise in an adult female patient, which was successfully operated under spinal anesthesia. The anesthetic concerns are the pycnodysostosise patients. Most commonly, they present with craniofacial anomalies, which can cause like hypoplastic maxilla and mandible, large tongue, high arched palate. All these can cause difficult bag and mask ventilation and also difficult laryngoscopy and intubation. Therefore, difficult proper preoperative assessment, airway assessment, and difficult airway cart should be ready before inducing the patient. And also, the regional anesthesia is preferred when indicated. And also, the risk of difficult intubation, it may increase with the age because the craniofacial anomalies also increases with advancing age. Some patients may also present with scoliosis, can cause difficulty in putting spinal and epidural anesthesia. In such cases, ultrasound can be used. Because of fragile bones, these patients are more prone to trauma. Careful handling should be done during shifting from ward and also in the intraoperative surgical positioning. And also, the airway manipulation during intubation, it should be minimal and careful to avoid injury to the cervical spine. These patients also have large tongue with elongated soft palate. So obstructive sleep apnea is common in these patients. Therefore, the airway obstruction is commonly seen in the post-operative period, which can be avoided by minimal use of opioids, and also the extubation should be done when the patient is fully awake. So hence, the detailed preoperative airway assessment, careful planning and management of difficult airway, and prevention of iatrogenic trauma by gentle handling with minimal manipulations are essential for managing a patient with pycnodysostrophy.
So now I would call upon Dr. Samarth, who operated upon this case, and would the intraoperative findings.
Whenever we operate upon such patients, such difficult patients, important things are how detailed it is given in literature and how much of these has been done before. Second is experience, our experience from the past and how we have dealt with these cases. However, in this case, these are very rare cases, and hence our experience was not there in dealing with these cases. And the literature, although there is some literature, but there is not a lot of evidence in literature about operating these cases as well. So the third thing, the only thing that we could do is to plan, and to seek the blessings of God. And I think in these patients, the only way to seek blessing is to plan these patients again and again. So even though it is known that these patients do not have a canal, but then to prevent a future fracture and to get the best biomechanical stability, it is best to do a nailing in these patients, which is why we try to do a TENS nailing in here, which is a titanium elastic nailing kind of a system where a solid strong nail cannot go in. This is the technique to do nailing in these patients. We, however, try to open the medullary canal because from our experience of other osteopetrosis patients in the past, we have seen that sometimes we can drill out a medullary canal out of nowhere. And we thought that, although the chances of that happening is low here, but we wanted to try our luck and we tried to open the medullary canal, but that wasn't possible. And we tried to insert a nail from both the proximal as well as the distal part of the metaphysis, but unfortunately we did not succeed in that. But then we had planned for these things in advance, so the plan changed, and intraoperatively we did a plating in this case. This is evidence that we tried to carve out a canal. We tried to take a strong drill bit, used multiple drill bits to try and make an entry point for making out a canal. Tried to get made some part of a canal in proximal third of the femur. But however, that was not enough to put in a titanium elastic nail, even the smallest size of that nail in this patient. And finally, we knew this could happen, and then we went on to plan B. So this failed, and then we wanted to do plating. Like Dr. Anupam has already discussed, that these patients, they can have longer union times, and hence in these patients it is best to preserve biology as much as possible. So whenever we have good amount of blood flow, then the fractures tend to unite faster. And if in these patients we somehow during our surgical procedure jeopardize the blood supply, then the union can take a lot more time than it normally will. And in these patients anyways, it is expected for the union to take a much longer time. So within the two types of plating using the same plate that can be done, one is anatomical plating, where we open up the fracture site completely, take off the blood supply, get the bones right into their place, and then put a plate with the fracture and the plate and the whole bone right in front of our view. Instead of that, we try to do something which is called as the biological plating, which just relies on the concept of restoration of the length, the overall alignment, and the rotation of the fragments, and it does not depend on actually physically seeing the fracture from all the ends and thereby taking out the fracture hematoma or jeopardizing the blood supply. Hence, we did select to do a biological plating. This is an example of an anatomical plating where you see the bones, see the fracture from all round, and then plate these. And this is an example of a biological plating. So this is what we did in our case. We first pre-contoured this plate on to fit onto the shaft. Otherwise, a strong plate sitting onto a strong bone with either bend the bone, and these bones do not bend, they in fact crack and fracture. So if the plate was not pre-contoured well, then the bone could have fractured at a different place. We needed to keep inventory in place because the bones are small, the patient is small, and the same plate that fits a femur in a normal patient would not fit this patient because she is anyways 10 years of age and has a very short stature. So we pre-contoured this plate, opened up the fracture site minimally, put on this plate and try to get as much as compression with the biological plating as possible when we operated upon this patient. And this is the intraoperative X-ray. If you see here at the top as well as the bottom, both the screws are not drilled all the way through because we did not want to leave a chance that this screw becomes too bicortical and then there is a stress riser here to get a second fracture. This is a technique that we use by putting a unicortical screw on either end to decrease the stresses at the end of an implant, hence thereby decreasing the chances of a stress fracture at the end of an implant or a peri-implant fracture in the future of this child. And hence this plating intraoperatively we felt that we were successful. This is a 4.5 narrow plate which is normally used for the humerus fractures of most adult patients. And this was there on the inventory because of the preoperative planning that we have already talked about. So this is the intraoperative picture where we have just opened upon the lateral aspect. We have not violated the medial cortical bridge or the medial tissues. There is no periosteal stripping when doing this plating. This is a minimally invasive plating. We have just slided the plate onto the bone without taking off the periosteal supply. I have already discussed how pre-contouring of this plate was very important in this patient because if the plate was not contoured, any force onto the plate going onto the bone would have fractured the bone at another place. And like already discussed, we used a lot of new carbide drill bits with a lot of saline irrigation throughout the procedure so as not to cause any heat necrosis of the bone in this patient to decrease the chances of non-union later on. We were quite happy with what we did with this case. This was the immediate post-operative X-ray of this patient, and looking at the X-ray and the stability that we had intraoperatively and the amount of support we gave this patient, we mobilized this patient with toe touch mobilization immediately after the surgery so that this young child would not remain in bed for a long period of time. However, when this patient came to us at 6 weeks, normally at 10 years of age, we expect the fractures to unite very well and very soon. Within 10 to 12 weeks, 6 to 10 weeks of time, we see a lot of callus formation or healing. But in this patient, they showed minimal signs of healing at 6 weeks. And however, we knew from whatever the little evidence or literature was available that these patients go on to have a delayed union or non-union. Hence, to get more stimulus of union, we allowed the child to wear now partial weight bearing at 6 weeks itself. The wound was absolutely fine and the patient has 0 to 90 degree of range of motion at this time, probably because of this little pain from the muscles that happens after plating in these patients. And that was the 6 months follow-up of period. And at this point of time, we saw that the fracture line was still persistent. Even in adult patients at normally 6 months of age, these fractures absolutely unite and it is very difficult to see the fracture line that is seen here. However, this bridging callus here on both the views was the saving grace and that made us happy. Although the healing was slow, but it was there and it was happening. And there was no tenderness at the fracture site. So there was no clinical sign of a non-union developing there. Hence, we started the patient full weight bearing mobilization, and the knee range of motion also increased to as good as the other side, which is 0 to 120 degrees. And this is the 10 months follow-up X-ray which shows a complete healing of fracture line. The patient has complete range of motion of the knee and there is no functional impairment. And the patient is doing absolutely whatever she was doing before this fracture has happened. And at 10 months, we do not see any signs of an impending fracture in this femur. Now I would like to call upon Dr. Nishank for the last two slides. This is the stature of the patient. She was just 107 centimeters in height, and this is after she was full weight bearing at 10 months.
Thank you, sir. So I hope listening to this case being shared with you all was as enlightening and illuminating an experience for you all as it was for us while managing it. So as surgeons, it is not always possible to avoid complications. But with enough expertise and insight, it is certainly possible to anticipate complications and be better prepared to handle them in the operation theater. So what we learned today was a very rare type of hereditary osteosclerosis, which is a condition known as pycnodysostosis, a rare disease of bone metabolism with brittle and hard bones. we saw it being presented to us with an orthopedic problem, a rather difficult problem in view of the condition of the bone, which precluded the use of what is our routine management, that is intramedullary nailing, and which forced us to think of other options that we can deploy to manage this case. The other phenotypic features of this problem also pose challenges to the anesthesiologist for both general and regional anesthesia. And as excellently described by our colleague from anesthesiology, the more you sweat in practice, the less you bleed in war, which is why preoperative surgical planning is the key to a successful outcome in cases such as these. And it is only with adequate preoperative planning, being aware of all the possible challenges, and having backup options during surgery that you can handle such cases. I thank you for your attention. I would now like to invite Professor Malhotra, our chief and mentor.
Good afternoon. The bones have their own personalities, They can be bent, crooked, twisted. They can be, soft. They can be hard and marble like this. They can be straight. They can be pathological. This one is a psychopath. So when you deal with it, you have to, really improvise and customize your approach to managing this. And as you have been told, it needs a lot of skill, a lot of patience, and a lot of equipment specially designed to overcome these kinds of problems. And then you've been told about the issues. They are so hard, yet they are so brittle. Then the issues of fixing them, the issues of the risk of infection, everything is compromised. So to be able to achieve a good outcome is really commendable, and it's really no child's play. I'm sure you'll have some questions. We'll be very happy to answer those questions.
Call Dr. Vivek Trikha as well as
For the last word. Any questions? It is available. We are not practicing it yet, but it is being practiced. The navigation and computer-assisted trauma surgery is being done at many centers in the world. So I think it's Vivek will tell you when he is planning to start.
Computer assisted is very much required for crooked bones, as I was saying. Most of the time, image intensifier is also, I would say, a primitive sort of a navigation which we can use. We have got very good images and OARM also, right? We are using such investigative tools, healings. These are routine cases, so I think that expertise of every resident and every orthopedic surgeon is so much that routine cases we may not be requiring navigation for. However, for a challenging or a complicated case where the bones are
to decrease the radiation exposure, we certainly are using a type of navigation which does without image, and that is for locking of these intramedullary nails, and that is something that sir and we have been using for a long period of time in our department for the last 7 to 8 years, ever since it is there in the department. No, it is computer-based navigation where we do not have to use a C-arm or an intraoperative imaging. It just decreases the radiation during the surgery for locking of these nails into the bone.
The technology is coming in a big way for trauma surgery as well. We have 3D printing, so you can actually print bone models and actually the exact bone how it is, so that you can plan your surgery where you have to bend your plate or what curves you have to negotiate during your surgery. Particularly navigation is particularly useful for also things like percutaneous procedures. If you, particularly in the elderly patients with osteoporotic fractures or something where you don't want to subject them to a big surgery. So it is the future. But having said that, I'll just say two things. One, that it is very important to be proficient in the conventional surgery before going on to either robotics or computer assisted, because your concepts should be absolutely. And second thing is, we are still a teaching institution. We can't sort of, totally jump onto technology, which our trainees may not be able to access once they're out of it. So we are maybe able to do something in a very advanced manner, but there has to be some surgeries being done in a conventional manner, if only to teach postgraduates and the undergraduates about how it is done. If these facilities, they are value addition, but they don't replace the concepts and the basic understanding. Thank you very much. If there are no more, yes, please. So again, that's something you like to respond, and I'll give my view about it.
It's not the instrument which makes the.
Yes, absolutely.
It's the person who is driving that horse or driving that vehicle which makes. I would say it's more of the expertise of the surgeon, as well as how well he negotiates and manages the nature of the result.
So let me put it this way. The good surgery is much beyond a good X-ray. When you do all this planning and navigation and all, you will get a very good X-ray, perfect reduction, but a reduction doesn't lead to healing. Healing needs biology. So in order to get that reduction, if you peel off all the soft tissues and the bone is dead, that good X-ray is not going to heal. So like he said, and like I also said a short while ago, it's much more important to have understanding of the underlying principle. And then these are incremental advantages that, you can get a 90% reduction by technology, maybe you can get 100% reduction. But then the basic principles have to be followed, that, the bone vascularity has to be maintained, to know what are the risks. If technology does in 6 hours what you can do in 1 hour, it's really, you have to weigh the benefits of the technology vis-a-vis this thing. So that's why I said you have to be an experienced surgeon, then you'll be able to catch where the technology is taking you astray. It's a computer. The garbage in, garbage out. If you give it wrong information, it will just mislead you. You have to be smart enough to even make sure that the technology remains your slave and not your master.